Today, we're lucky to have two speakers. Dr. Saraswathi Vedam is the lead investigator of the Birthplace Lab at University of British Columbia. And for over 35 years, her work has set standards for international policy on place of birth, midwifery integration, and measurement of high-quality perinatal services. She led the provincial community-based participatory studies, Changing Childbirth in British Columbia, and the Giving Voice to Mothers study, and the RESPECT study, exploring experiences of respect, discrimination, and mistreatment during childbearing care in North America. These projects have led to new quality measures, the Mothers Autonomy and Decision-Making Scale, and the Mothers on Respect Index, and the Mistreatment in Childbirth Index that assess quality and safety as defined by the service user. These award-winning instruments have been applied in research and quality improvement in 23 countries. Professor Vedam also has convened transdisciplinary delegates at 4 national birth summits and for a Global Perinatal Taskforce on Quality and Rights. Our second speaker is Tanya Kemet Taiwo, who is an assistant professor of midwifery at Bastyr University and co-director of the Community Engagement Core at the UC Davis Environmental Health Sciences Center. Her research focuses on prenatal environmental exposures that impact neurodevelopment and how maternal stress and racism exacerbates these exposures. Dr. Taiwo is a research fellow at the Birthplace Lab at University of British Columbia, where she's collaborating on the Giving Voice to Mothers study, a research project that examines how race, ethnicity, and birthplace affect maternity care in the United States. She has decades of experience working as a licensed midwife and co-founded a network of women's health clinics in medically underserved areas of Sacramento. These clinics address the multifaceted needs of low-income women and their children in a model of respectful preventative care that was both empowering and collaborative. So welcome, Dr. Vedam and Dr. Taiwo. We're so glad you're here, and take it away.
Thank you so much for that kind introduction, and welcome everybody. I will share my screen. You're able to see it now?
That's good.
Mm-hmm.
So I'm coming to you from the traditional and unceded homelands of the Musqueam, Tsleil-Waututh, and Squamish nations of Western Canada, known now as Vancouver. I'm here to speak to you along with Dr. Taiwo about a study that we did, a national study that is still producing new information about equity, safety, and respect from the service user's perspective. And I guess we're here to speak to you a little bit about equity and what it means to us as clinicians and clinician researchers to center the most marginalized. We are, of course, in a year of reckoning around, or 2 years of reckoning around our collective responsibility to center the most marginalized and historically excluded in our world. And so today we hope to review what we've learned about the lived experience of care through participatory action research, and then propose a roadmap to expanding equity in our work. So when I give talks, I've learned that the important thing to remember is that all research in our practice and our engagement in the world is influenced by who we are, and we should be transparent about how that influences how we see and understand the information that we get. And so to tell you about what informs my research and practice, I'm a settler in Canada, which is how I'm also an immigrant. I grew up in a first-generation immigrant family in the United States. I'm a cisgender woman of color. I've, in my life, experienced a lot of privilege in education, housing, personal safety, and also I and my family have felt the impact of discriminatory legal systems, incarceration, untimely loss, and race-based and profession-based discrimination and privilege. So, of course, all of that comes into the work that I do and how I interpret the data. Right now, I am still a practicing midwife, but I also run a lab called the Birthplace Lab, and we are engaged in examining and understanding the lived experiences of health services particularly around perinatal care, around birthplace and provider, and around how decision-making and interactions between service users and the health system play out. So some people call that reproductive justice work. Other people talk about it as action research, but in any case, that's what we do, a lot of participatory work. We have no conflicts to declare. We have various funders along the way that have supported my lab. And as you can see, just a tip of the iceberg of all my collaborators on this Giving Voice to Mothers study that we're going to talk about. And one of the earliest collaborators was Dr. Tanya Kamet-Taiwo, who will speak with you also today. So let's just start by talking about how we enhance quality in research. You know, most people will say that we need to ask the right questions, ask them in the right way, ask the right people, and ask enough people. I would say most researchers really concentrate on ask that enough people, like, you know, do you have a large enough sample size? You know, can you believe it? Are the outcomes, you know, the incidence of outcome that you're looking at, can it be talked about, you know, with the sample size you had? But in our lab, we really are concentrated on measurement that is credible. So asking the questions in the right way. And we start by asking the people, since we do health services research, we ask the people who are most effective to help us design those questions. Until now, 90% of the research and funding has been focused on the study of conditions that affect less than 10% of the population. So that's in that small circle you see up in the right, which is the first line management of complications. From 2014 to 2018, the Lancet published 3 series based on global systematic reviews on the impacts of the model of care on maternal health. They had a series on midwifery, a series on maternal mortality and morbidity, and a series on the optimal use of cesarean section. And through that process, this definition of what quality care is came under discussion. So this is one framework that some of those authors put together about all of the other parts of that influence quality of care that haven't really been examined. We don't know even now so much about the how to optimize the biologic, physiologic, and psychological environments for pregnancy, labor, and birth. We don't know that much about the how organization of the care, anticipatory guidance, preventative care, all that interacts with the experience of quality. The WHO in 2016 published standards around quality care, and for the first time, they elevated the experience of care to be as important as the availability of skilled personnel or facilities and resources. And so you can see here, effective communication, respect, preservation of dignity, and emotional support were suddenly really being codified. And they've in this document, they actually have it really broken it down as to why it makes a difference to quality and safety. So over the past decade, my lab has engaged in a number of these studies to examine that, exactly that. What are those? And so today we're going to talk to you about the Giving Voice to Mothers US study. It was based on some tools that we developed in the Change in Childbirth in BC study, which was a provincial study. And we've just completed a very large national study here in Canada too, which has, double the participation, even during COVID, probably because we're asking questions in different ways. So the model that we've put together for this participatory work is how we center the community is that the community stakeholders, we always start by putting together a steering council of community members who want to work with us. They help us bring in other multidisciplinary stakeholders. Together we seek funding. They help us create the study instruments. Maybe it's a survey tool, maybe it's a focus group. Then they also engage in recruiting participants. We have regional recruitment coordinators who are usually service users themselves and are reaching out to their own communities. And then they are engaged in exploring the findings and identifying the key messages and deciding how to tell the story and who to tell the story to. So in BC, we had a steering group of women, self-identified women of childbearing age from different cultural, socioeconomic backgrounds. And there were 4 working groups that emerged from that. This was back in 2013 and 14, when I would say our language, even in research, was not as inclusive of diverse gender and sexual identities. So this is when I just as to say, when I'm talking about women, it doesn't necessarily, we weren't asking the right question, so I can't say for sure that everybody self-identified as a woman, but all the people who participated certainly were reporting on pregnancy and childbearing experiences that they had themselves from these different backgrounds. So it was provincial data collection, urban, rural. We did end up having a representative sample, and it was available in several languages. We did some focus groups, actually 20 of them around the province as well, and provided honoraria and childcare and meals so that to help people participate. In the process of creating the steering, the study together, they chose the topics, they chose the methods, and they worked together to help us choose the best questions to measure those topics. In BC, they said they wanted to us to explore how their access to different models of birth care. They wanted to talk about birthplace and decision-making and these concepts of respect and autonomy. When we brought the same, after we did that study and we came to the US somewhere in that process, and we were engaging communities of color and people who chose community birth, so that's home and birth center birth, because they had not been able to tell their stories yet. They then, these communities of color in the US, told us that those things are all important, the place of birth, access to models of care, decision-making, but that we really need to measure and understand these experiences of racism, mistreatment, what happens when they consent or decline procedures. And most importantly, especially the Indigenous service users said that it's important to look at the other side of the coin. What builds health and well-being? What is working, and how can we replicate that? So we started by doing a literary review and a Delphi process we started by doing a literature review, and then later also did a Delphi process to decide on the best ways to measure these concepts that haven't been measured before. In both the US and Canada studies, we've always started by selecting what's out there and validated, adapting them or designing news questions when we need to. And then we take it back to the community. It's an iterative process. They will formally rate it for relevance, clarity, and importance along a 4-point ordinal scale. So it's quantitative content validation, but with an expert panel. And then we will pilot test it too. So it's a long process to get to the right tool. In BC, we looked at the Listening to Mothers study, which you may be familiar with, was the only set of national representative surveys around experience of pregnancy and childbirth care. Unfortunately, it was focused only on people who chose institutional birth or hospital birth. So we didn't have as much, we didn't really have the information about why people were choosing community birth, which seemed to be a growing and continues to be a growing trend. And we did not, it was, while it said it was representative, it was represented on a census definition of the communities. And so we decided to do, to deliberately oversample for communities of color. We also pulled in, validated, when we knew there was research about why, say, people chose community birth, we turned those into ways of asking, using what was known already in the literature if they didn't have a measurement tool. So that led to some person-centered measures of quality care. And I'm going to tell you sort of a taste of the types of questions we asked, and then Dr. Taiwo will tell you the results that we got from the Giving Voice to Mothers study. So we have here, we put together some scales. So we had, I guess we had to to understand a complex concept like respect or autonomy, you can't just ask a single question like, did you have autonomy? Because what does that mean? And, you know, what's their baseline? And what are we really talking about? They're having autonomy about. And so what we did, in BC, when we did this huge study that mushroomed and we didn't have enough capacity to, or resources really, it was a small grant to analyze all of the data we got at the time, we asked the service users, what should we focus on? And they unanimously said, you need to look at that decision-making and how, what's happening in our conversations with our providers. And so we went into the survey and found items that had to do with how people ask questions and how they got information and what those interactions were. And that led to the development of two scales, one on autonomy and one on respect. So we went through this process of adapting the items around decision-making process and 7 items measuring respectful care, and did formal fact factor analysis. For those of you who are understand about that, it's you see in any given study, how do people tend to answer these same 7 questions that have to do with, you know, a similar topic, and you do what's called factor loading, where some of the answers, positive or negative, so you can see the purple and green will all kind of group together in the same direction. And so this is just a visual of a scale that has 3 different types of things that they're they're measuring. And I'm going to show you what that looks like when you see the second scale. But the first scale that we developed was the Mothers Autonomy and Decision-Making Scale, which has service users agree or disagree to these statements on a Likert scale. So my doctor or midwife asked me how involved in decision-making I wanted to be. They told me there were different options. They explained the disadvantages and advantages, helped me understand all the information. I had enough time to thoroughly consider the different care options. I was able to choose what I considered the best care options. And my doctor or midwife respected my choices. It's important to understand that this started out as there was a 9-item scale that was developed for decision-making around cancer. And so I brought that scale to our group, and when we did the literature review, and they said, well, this is great. It says about how involved I wanted to be in decision-making and that I have different options. But this scale, first of all, of course, it wasn't about pregnancy and childbirth care. And it also didn't have any option in that shared decision-making scale that pre-existed. There wasn't any option for them to say they were able to choose what they considered, that they had time, that their choice was respected. So they actually adapted that scale, added 4 new items, and we then did the psychometrics to develop this. So this all leads into a score. So if you get a 1 to 6 score, depending on whether it's what your answer is, and that tells you a high score of 42 would be very high autonomy, a low score of 7 would be very low autonomy during those conversations. So it's been now adapted. It's available in 12 languages and in 28 countries. It's been performed well. And this is the Mothers on Respect Index, the MORi score. So this is the one that I said is measuring 3 different aspects of a similar concept. So we're calling this respect. It also talks about how those interactions between the service user and service provider are, and whether or not, how comfortable they feel, whether they feel pushed or coerced into accepting options. And then what happens? Do they feel like they were treated poorly because they have a difference of opinion, because of their identity, because of their resources? And how does that affect their behavior? Does that mean that they hold back from asking questions or discussing their concerns because they think that they'll be seen as difficult or that their provider is too rushed? So this is a little more complex scale, but does measure this complex idea of respect. Those scores then can be used as an outcome measure, right, to whatever the condition was. Similarly, our service users said that it's not enough to just ask, what was your income? That doesn't tell you the whole picture. What about if our electricity was turned off, or we needed assistance, or we didn't have enough ability to buy food at the end of the month? And when you talk about our risk status, whose definition of risk is that? And what about those social risks? So we created these composite measures based on what they were telling us was important, and that we could get a rounder picture. So Dr. Tywell now will, I will stop sharing, and she will go through the results. This picture is just to show you that our service users were also very involved in how we recruited people, and what the images were. They said you can't have a particular race or ethnicity, and you can't have someone who's so pregnant. What if they have a loss? And then you will not be inclusive. So we were learning always through this about how to get people to participate, because they could see themselves even in the recruitment materials.
Okay.
Over to you, Tanya.
All right. Good. You're seeing the same flyer that you saw before?
Yeah.
Wonderful. I do want to just say that I am coming to you here from unceded Eastern territory, and part of the reason why I'm so excited about doing this presentation with Dr. Vedam is that it is at UCSF where we met many years ago, when she had convened a steering committee for the first National Home Birth Summit, and and that convening and the work that followed is what has led to, all of this incredible research that she's been talking about. So anyway, it feels like a little bit of coming full circle. So, with all of that intentional community engaged work, we ended up with a beautifully representative sample. And our partners distributed the survey widely through social media, clinics, baby stores, and also their own networking. And so the respondents are spread across the country, all 50 states, and really mirrored the US population density. For example, we had 10% of our respondents were immigrants, and 30% were low and middle income. And we deliberately oversampled for folks of color, and also those who planned home and birth center birth, and particularly using these community networks, using snowball sampling, and quite a bit of social media recruitment. So we achieved slightly more than the US Census for Black and Indigenous respondents. Accurate percentages for US Hispanic, Latina, or Latinx population is at, and 10% of the Hispanic respondents were not Black or non-Indigenous. So all but 33 women had previously given birth. And so we had respondents reporting on maternity experiences that resulted in a loss. 13% of the women were pregnant at the time of data collection, and most were between the ages of 31 through 40 at the time that they responded to the survey. And so let's get to some of these results. About half of the sample had a planned hospital birth, and the other half gave birth in the community, spread over home and birth center. And you'll see here that the place of birth differs by the ethnicity as well. We also had a wide range in types of providers. However, you'll see that more Black and Latinx respondents had a physician only, or hospital-based midwives only. So this is one slide that I particularly was very interested in and also quite appalled by. So you'll see that the blue longer bars indicate where respondents said that they needed help. And the red, much shorter bars indicate that that was where they actually got their help throughout the course of their maternity care, whether it was provided by a doctor or a midwife. And you'll notice that the only place where needs were met had to do with help with quitting smoking. So that's the place where maternity care providers did a good job. And I do want to highlight that one area that the respondents did not get support was important areas of mental health. And so also the unmet needs included nutrition counseling, intimate partner violence screening, and safe housing, and also navigating social safety net programs. So, but when we dive a little bit more into the unmet needs for perinatal mood disorders, we'll see that 6% of the sample had an unmet need in that area. And this also matches a lot of the research that we're not doing, even though universal screening guidelines exist. Care providers overall are not following our universal guidelines. And so we see that mirrored in our study. Then when we compared communities with using white women respondents as our baseline, Black and Indigenous women are more likely, 2 to 3 times more likely to not have their needs met in this area. So something for you to puzzle over. And so we also asked them, as Sarah said, we wanted to look at, the concerns, and generally we healthcare providers, we look at concerns that are violence in the home, and but our steering council said we want to tell you what we're concerned about, and you'll see that violence against their families or community members were what they were most concerned about, more so than violence inside the family. Or and we also see differences by race in terms of where with Black folks expressing the greatest fear and concern for violence in their community or against their community. Here's another place where the steering committee said, we want to tell you what makes us survive, succeed, and thrive. And you'll see that healthcare providers are quite low on the list. And so we need to be really mindful of that in our work, that what people are saying is that it's the immediate family and friends and extended family and their faith community. And so we should be acknowledging that when we are working with folks. And I just moved. So we also asked, was it important to you to find a healthcare provider who shared your heritage, race, or background? And was it difficult? And you'll see that for most people of color, it was important to them, very important to them, but very difficult to find. And we engaged actors to articulate some of the open-ended responses within the that people gave us.
My OBGYN was a Black woman, and the attending doctors during my birth were both women of color. I felt both respected and heard throughout the process?
Oh, Sarah's talked before about decision making, and this is what we found in the study, that that only a small percentage, only 26 women out of the 2,700 said that it really wasn't important, that they lead decision making. And so that works out to be about 1%. And about 1/3 wanted their provider's input. So they really are telling us that shared decision making was their desire. Now, when we look specifically at the decision to have a C-section, most of the time this decision was made by the providers, and we have let's see. Most of the time, the decision was made as a provider, by the provider, with 13% of our sample, who had cesareans. And here's another story told by one of our survey respondents.
I was dropped by my provider at 37 weeks pregnant because I refused the 4th glucose test. I took it anyway, and they sent me a firing note the day after. I had to ask them to take me back as a client since no other provider would help me, and they required me to sign something stating I would do whatever they asked of me.
So you would see that it were that particular respondent to were she to fill out the MADM scale, she would have a low score. And Sarah's talked about the MADM scale, so I'm going to keep moving. So what we found when using the MADM scale in the Giving Voice to Mothers, we found lower autonomy in hospitals, and increasing autonomy as we moved outside of the hospital to the birth center, and then the greatest autonomy at home. And when we looked at autonomy by provider type, we found increasing autonomy when the provider was a midwife, and a statistically significant difference between the types of midwives that were cared for by our respondents. So yet there were significant differences between the care offered by physicians versus midwives. Overall, autonomy scores, the difference between there was a difference between Black service users. So I do want to point out that in this Fisher plot, that the mean is this gray line. So we see a more pronounced difference among Black respondents in our study. And many of you have recently perhaps had to complete the implicit bias training that was required by Senate Bill 65 that passed, the Dignity in Pregnancy Act that passed in California. And so we also measured implicit bias in the Giving, and found it in the Giving Voice to Mothers survey. So hopefully we'll see, as more and more providers in California begin to take the trainings, and we improve the quality of the trainings, hopefully we'll see a little bit less of this. All righty. And so when Sarah spoke about the RESPECT scale, when applied to the Giving Voice to Mothers survey, we saw that people of color reported the lowest levels of respect, with Indigenous women in the reporting the actual lowest. And all of these differences were statistically significant. So as Dr. Vedam said, we have multiple researchers who are continuing to work on the rich data that we achieved from this from the study. And Dr. Palomi Niles at NYU, Melissa Gradil and Nan Strauss examined the intersection of the model of care and place of birth. And what they found is that midwifery clients who gave birth at home or in a freestanding birth center were 5 times as likely to report very high autonomy compared to physician clients delivering at the hospital or hospital-based birth center. So what they concluded is that the place of birth and the type of provider, as well as the mode of delivery, all matter when we're looking at both autonomy and respect. So we also, Dr. Vedam mentioned the mistreatment index, and so community members told us that these were the types of mistreatment that they experienced. And that is where the MIST index was developed from. And so they wanted to see what others said. How often is this happening? And who is most at risk for mistreatment? We found that 1 in 6 or 17% reported being shouted at or scolded, that providers withheld treatment, delayed their response to requests for help, and or threatened them. And this is something that you would not expect that any person giving birth in the US would experience, but yet still, these are the findings. Then, when we looked at people of color, we found that the rate of mistreatment doubled for those respondents. And this is very same as the mistreatment, the prevalence of mistreatment in low and middle income countries that was reported on in the Lancet in 2019. Did I get that right, Saras?
Yeah, that's right. It was interesting that, you know, a lot of times in North America, we say, oh, that doesn't happen here. That's just low resource countries. And that's because, you know, and we found, we published in the same year, and it was exactly the same rate of mistreatment. Slightly different types of mistreatment, but, you know, all within those seven domains.
Yeah. And so, and we also found when we dug even deeper that the way that people gave birth affected their rates of mistreatment. And also, as with autonomy, the type of provider mattered. With, in this case, greater mistreatment is above the line, and experience with OB providers, and less mistreatment with CNMs and CPMs. Another.
My original OB/GYN was rude and insulting to me and said that I risked having child protective services being called on me if I refused antibiotics due to being GBS positive.
So, to repeat, 1 in 6 women in our sample experience one or more types of mistreatment. Then, when we examined, you know, what are other factors linked to mistreatment, we saw that it increased with any social risk factor. And remember the composite variables that Sarah's talked about, that our steering committee helped build. That as you increase the social risk factors, as you increase differences from, you know, the perceived norm, the level of mistreatment increases. So here, then we looked at how two-eyed seeing, right? How do race and other factors intersect? Really, and so we did a stratified analysis at looking at additive factors that are already known to interact with poor outcomes stratified by race. And we are seeing how the increase in mistreatment based on, for women of color, and as we look at these intersecting factors, and we are using this as a guideline for future analysis, because this is work that really needs to be fully dug into. So one of the women, one of the respondents, you heard her talk about, declining care. And what we found is that that white women were more likely to be supported in their decision or accepted in their decision to decline care. But but there was a difference when people of color declined care. And so 79% of those folks who had a difference of opinion with their provider reported mistreatment. So women of color were twice as likely to have care providers perform the procedure against their will, or to continuously ask until they agreed, or trying to subvert them and asking family member to convince them to agree with their opinion.
Tanya, just to pause you here, go to the next slide. Dr. Rachel Logan, who is on the call right now.
Oh,
so maybe we should let her present her own work. So
yes, how fantastic, Rachel.
Thank you for this opportunity. It was a bit of a surprise, but I will do my best.
I would have asked you. I didn't know you were going to be here. So, but of course, we're not going to present your work when you're right here.
So I did a secondary data analysis looking at people's experiences who completed the survey that they just described, and specifically looking at pressure to accept procedures. And there was a range of procedures that we defined as perinatal care. So for example, an episiotomy, putting erythromycin in the baby's eyes, administering vitamin K, and if people experience pressure to accept that. So about 30% of people said that they were pressured into accepting procedures during the perinatal period, but specifically around the birth period and other procedures related to newborn care. And about 44% of people said that procedures were performed on them without their consent. And that is also related to these similar procedures of an episiotomy, erythromycin being given to the newborn, as well as the timing of cord clamping being done without their express consent. This was significantly higher among BIPOC folks in general, with there being about 39% of the variance is explained. Also, when looking at the higher mean, so initially when we did the analysis, we combined these factors into a score. And when looking and comparing the scores, we also saw that higher mean pressure scores were associated with more induced operative vaginal and surgical births compared to facility-based births. To community-based births. So folks in facilities experience more pressure than those who reported giving birth at home or elsewhere in the community at like a freestanding birth center. I'm not sure if there's another slide.
No, that's it.
That's it.
Yeah, thank you,
Wow.
Rachel.
Thank you. Thank you, Rachel. That is
And,
lovely that you're here.
this article that Dr. Logan was authored, first author for, is coming out very soon in the Birth Journal. So it's look for it. It'll be sometime in the next month.
Good. And Dr. Dana Solomon looked at the relationship between BMI and mistreatment and autonomy, as well as respectful care, non-consensual care, and also disparities in access and social determinants of health. And what Dr. Solomon found is that larger people were almost 5 times as likely as those with a normal BMI to report mistreatment, including loss of autonomy, so being shouted at, scolded, threatened, being ignored, refused, or receiving no response to requests for help. People with a BMI over 40 and with no other adverse health conditions were 6 times as likely as normal weight parents to be pressured into a cesarean section. And Saras, is this also, are we looking to see this get published soon, or is this?
She's working on it. She was on a medical leave, but is back now, and so should be.
Okay, so keep your eyes out for these 2, fantastic papers. So this is another secondary analysis looking specifically among a cohort from the Southeast US, and where a part of the country that has really terrible perinatal outcomes, or some of the worst perinatal outcomes in the country. And this analysis focused on Black birthing people, because in addition to Indigenous folks have the worst outcomes. Of course, we no blaming here. These are just, we're addressing the structural factors of inequity rooted in systemic racism and these intersecting oppressive systems. And so Dr. Julian, from this region's specific analysis, found that the odds of any mistreatment, low autonomy, low respect were higher among Black and BIPOC participants. However, irrespective of participant race, midwifery care in community settings was protective against mistreatment, low autonomy, low respect, compared to physician-attended, midwife or physician-attended hospital births. This was presented at APHA years ago. So why does it matter? Why do we care? And already Dr. Vedam answered this question, because these are the questions that haven't been addressed as we've reported on disparities and continue to measure healthcare disparities and kind of thrown our hands in the air like, oh, we don't know why they exist, right? But you may have read the California Pregnancy Associated Mortality Review that was released and read across the country. And because it was such an extensive and rigorous high quality review of maternal deaths. And they reported that the most common contributor to maternal deaths were healthcare provider factors. Delayed response to clinical warning signs, followed by or inclusive of ineffective care. So mistreatment, lack of autonomy, lack of respect, all matter because they have a direct impact on maternal mortality and morbidity. And we also need to recognize address, what are our working conditions for providers? What are the structural factors that contribute to this type of treatment? And what are the resources for training that are there? And now I'm going to turn it back over to my colleague.
Thank you, Tanya. I'm just going to finish up. I know we're short on time, so I'm just going to finish up with a couple of thoughts from us about why we do this. Are you seeing a slide that says decolonizing the academy there?
Yes, we see it. Looks good.
Yeah, so what we mean by decolonizing the academy is really this idea that we have these systems, even in research, that have been doing things the same way, business as usual for a long time, and it's not gotten it right. So I think what we've learned and keep learning through this participatory work is that we have to not have so much hubris, that we have to bring our humility and our self-reflection to the process of research. That in fact, maybe we need to re-examine the questions and the methods and the ethics. I know there's a lot on this slide, but what about recruitment and retention of racialized scholars? What about who chooses the questions that are asked, and not codifying the control group as the standard human, or using terms like non-white, because obviously if you're non-white, I don't ever think of myself as a non-something, I am a person of color, I'm, South Asian woman. So, the language matters, valuing the lived experience matters, that principle of nothing about us without us is I think really where we need to bring it into, and even our research teams need to have a representation. What would happen if we, instead of looking at risk and blame the person who is experiencing the care, what if instead we look at the other side? What if we measured undisturbed birth rates and culture match care, or respect and disrespect alongside models of care? What if we measured racism and anti-racism and the impact of model of care and place of birth, and in a way that we could actually change the story? So what's working as opposed to what's not working. I think it's also important to acknowledge the expertise and contribution of the people who provide the data. Very often we go out and study populations at risk, and their voices are not brought back into it. They don't necessarily are the ones who are choosing what to focus on. I think if I had not had that advice earlier, we probably would have done the usual outcome data and experience, and whereas they said spend the money on the autonomy and respect, and now we have a whole new way to measure things. So there are some sociologists who really thought about this and answered the question about why we would admit that our expertise is limited and partial, or even colonizing, and they point out that when you engage in this type of work, it's liberating, that you actually feel so much better, like you're doing what you set out to do. And Gachi Cook, a wonderful elder from Canada, talks about this as a systems level disruption. She said, such a powerful shift would promote reproductive rights aligned with human rights standards, such as right to culture, right to health, right to security, and right to justice. So I encourage you to read. She's a very eloquent writer and makes us think about these things, and that how we can actually co-create these innovative models of care. So thank you. I think we're close to the top of the hour, but maybe there's time for a few questions.
Thank you so much, Dr. Vedam and Dr. Taiwo. We really appreciate you being here virtually to talk with us. And I know, thank you, Dr. Logan, for jumping in and talking about your research unexpectedly. I know there are a couple of questions in the chat, but also want to invite people to put yourselves on video if you'd like, and share questions out loud. And I'll read one question in the chat. Gia, I'm gonna summarize your question, which is gratitude and being inspired by this work and asking about factors for survival, success, thriving, including family, friends, and faith community, more so than healthcare. She is curious how examining these factors might inform how healthcare is reimagined to better support mothers. And are you all doing continuing work in this area?
Thank you. Yes, we don't have time to go into it, but certainly there, we have created a model for person-centered decision-making where you center the service user, and we have a course that we are teaching that kind of decision-making based on what the service users have told us. We have colleagues on our multidisciplinary team who are human rights lawyers who've created kind of a toolkit for service users to know how to say no. And, you know, we have that, of course, from the Me Too movement, and we need it around reproductive rights too, about how to decline care without encouraging backlash. And we are working with communities all across North America around these community-led solutions. You know, what do they suggest, and trying to elevate models of care that are culture matched. We have some another, we didn't have this today, but there's another article that came out of this work, which talked about birth center and culture-centered birth centers and how it's better for everybody, not just for communities of color. So we are definitely continuing with the work in partnership with the community members and listening, you know, and trying to action what they say is most important. But we're just, you know, I have a small lab where a lot of this is done off the side of our desk, because it's not the kind of thing that gets huge funding like some of the, you know, the latest molecule or COVID therapies. And so that's why I'm so grateful to have all these other scholars who have joined me in this work. And yeah, we'll just keep on. All we can do is keep on keeping on, right?
There was also a question about creating accountability for providers who offer care in facilities, and particularly non-consented care. And that is such a critical question. I think, you know, there's many levels of creating accountability, right? And part of that is the change in culture that we are seeing. And you know, but first of all, you have to know that it's happening. And that's one step is, you know, beginning to utilize these measures, these patient-centered measures, measuring autonomy, measuring respectful care, measuring mistreatment, and then, you know, bringing that out to providers to say, this is what's happening here in our facility. This is what our folks are saying as they leave. So I think that, you know, that is a critical component of building accountability, knowing that it's happening and needs to change.
Yeah, some of the toolkits, and they say that the birth rights bar has great things for service users. My lab's website it's www.birthplacelab.org. There are a lot of the measurement tools, the person-centered decision-making course, the infographics. They're all available there, and then links to our other colleagues who are working on this work. So yeah, we're trying to make it broadly available. We have another tool called the Underserved Labor and Birth Index, which is being implemented in hospitals in 3 states now to try to have institutional accountability around this kind of quality care. So we invite you all to join us.